from the beginning. Great. Hopefully everyone can hear me. This is, thank you very much for joining. This is the March 31st Connecticut Health Policy Project webinar on national health reform and what it means for Connecticut. I'm Ellen Andrews, Executive Director of the Connecticut Health Policy Project. We are very lucky to have Joe Courtney, Congressman from Connecticut's 2nd District, and one of our founding board members here at the project to explain all of this to us. As you'll see from the slides, this is a complex issue, and this is only the beginning of conversations on healthcare reform in Connecticut. At the end of the slides, you'll see information on where to find out more, including an excellent page on the Congressman's site, on the Congressman's website that has lots of information. A little housekeeping: if you are listening on the phone, remember to input the audio pin that should be visible on your screen into your phone. If you're listening on a headset directly through your computer, you don't need the audio pin. We will be keeping everyone on mute throughout the call, but we will have some time at the end for questions. You can type your questions into the question pane text box on your screen at any point in the webinar. The slides and a video of this webinar will be posted online soon on our webinars page at the Connecticut Health Policy Project. Representative Joe Courtney is proud to represent the 2nd Congressional District of Connecticut in the U.S. House of Representatives. He was first elected to the House in 2006. He serves on the House Education and Labor Committee and House Armed Services Committee. On the Education and Labor Committee, he sits on the Higher Education and the Health, Employment, Labor, and Pensions subcommittees. He's also the first congressman from the 2nd Congressional District to sit on the House Education and Labor Committee since World War II, which is notable given that Eastern Connecticut is proudly known as the Higher Education District of Connecticut. Before serving in the House of Representatives, Joe Courtney represented the citizens of Vernon in the Connecticut General Assembly from 1987 to 1994. During his tenure, then State Representative Courtney served as House Chairman for both Public Health and Human Services Committees and also chaired the Connecticut Blue Ribbon Commission on Universal Health Insurance. So Joe was talking about ensuring Connecticut's uninsured before it was trendy. He was recognized in a legislative poll in 1994 by Connecticut Magazine for his bipartisan efforts and named the most conscientious and the Democrat most admired by Republicans. So I will start, Joe, and you can start whenever you're ready.
Great. Well, thank you, Ellen. And, you know, it's been a long time since you ventured out courageously to start the Connecticut Health Policy Project. It obviously was driven a lot by your own strong, passionate commitment to a fairer and more rational healthcare system that provided a basic level of coverage for all citizens in Connecticut, but the country as well. And clearly, the events of the last couple of weeks are watershed moments for you, for a lot of your listeners, and certainly I feel totally privileged to have been on the floor of the House when we had both of those votes, moving this issue forward in a historic fashion. But, you know, rather than sort of spending a lot of time dwelling on, you know, the long, hard road, I mean, really, my experience has been, and it ought to be, the experience of most people, is that there is just a great hunger out there to figure out how does this get implemented, what does it mean to me and my family, what does it mean to the state of Connecticut, and holding this webinar, I think, is critically important to making sure that a lot of the bad information that's out there can be rebutted. And we put together a number of slides. Why don't we go to the first one, Ellen?
Okay. There we go.
Which, actually, I guess we can keep going to the next one. Immediate benefits. You know, this is a bill that is time-released over a period of time, as I'm sure many of you know just from following in the media, if not more specialized sources. And you know, for many people, the immediate effect is going to be almost zero. If you're in an employer-based plan that is particularly in the large group area, you know, with benefits consisting of fairly comprehensive coverages, but in terms of the net benefit of people who are struggling right now with the gaps in the system, in 2010 there actually will be immediate change that will be noticeable and meaningful. And this is the summary page, which shows some of the changes in terms of how insurers now have to begin to accommodate a new reality where coverage for pre-existing conditions is going to be required. Initially, again, it's children up to age 21, and the insurers confirmed just within the last 24 hours that they intend to comply with that language in the bill, even though there was some quibbling about whether or not the language was, in fact, bulletproof enough. The practice of rescissions, canceling coverage when people get sick or canceling after the fact, is now prohibited by law. And lifetime limits, one of those factors that exists right now that drives people into bankruptcy, is now no longer permitted. Children can stay on parents' policies to age 26. HHS is in the process of working out regs to make that totally the law of the land. We're told it's going to be within a matter of 6 months. But certainly graduating seniors from college and their families will benefit from that as commencement day approaches. The Medicare donut hole relief will occur this year, $250 payment for people who are within the donut hole, and over a period of time it will be eliminated. There is a reinsurance fund for employers with early retirees, which is to, again, help stop some of the shedding of benefits that's going on in that market. And the feature that I think is frankly the most important in terms of messaging and getting the word out is this last one, which is tax credits to small businesses who provide health coverage for firms 25 or less. And for the small business community, which is particularly concerned and skeptical about this bill, to realize that in year one that they are now going to qualify for a tax credit up to 35%, depending on the mix of employees that you have in their wages, is certainly a far cry from threatening, damaging government policy for employers who are trying to provide benefits. And again, this isn't just for new coverage, it's for plans that are already in place. If we want to go to the next slide, again, these next series of slides just sort of go through those changes in a little more detail, and we can just keep going. In this slide, if we could stop for a second, just shows an example of that small business tax credit, which for a nonprofit, let's say with 9 employees, it shows a wage factor and benefit factor, and it shows the net tax benefit in year 1, 2, 3. In 2014, this tax credit is actually going to get even bigger for small businesses, and as you can see, that's a substantial plus in terms of savings for the part of the market that Ellen's done so much work on that clearly is the hardest hit. I want to go to the next slide. Again, this is another example of a small business with 10 employees, wages of roughly $25,000 per worker, and the net savings with this tax credit. Go to the next slide. A diner with part-time employees, again, would be another example of a small business which will benefit in 2010, year 1, from the health care bill. Next slide goes now into the long-term benefits. Again, this is a summary page, which
I went too far. Sorry.
Yep, okay. Which again shows that in 2014, pre-existing conditions will become a thing of the past for everyone. The practice of gender rating is going to be illegal. The purchasing exchange subsidy system will cap out-of-pocket costs, and again, we'll see some figures on that later. It caps premiums that are bought in the exchange. Again, the tax credits, which we saw in the prior slides, actually get better for small businesses and for people. Got a couple of wellness things with nutrition labeling. Rosa DeLauro's great work on that issue, and the process of closing the donut hole, which began in 2010, again, makes incremental changes over a period of time. Again, next slide shows, again, the insurance reforms, which will go into effect concurrent with the establishment of the purchasing exchange. Again, I'm not going to read through all of these, but it's my understanding Ellen will make these slides available to listeners, so we can just keep going to the next one. And this, again, is, maybe go back to that chart that was, yep. Again, this shows the premium subsidies that will be in place for individuals and families up to 400% of poverty, and shows the monthly premium, which, again, using figures that have been supplied by the Congressional Budget Office in terms of what the cost and the subsidy would actually be. Next slide. Again, another example of what the world will look like for a family with no health insurance today. The cost of premiums for that family in 2014, again, based on CBO estimates, would be about $11,000. You know, they would save $6,000 with the reforms that are being discussed. Again, in my opinion, these are conservative figures by CBO. You know, I think, frankly, the existence of the purchasing exchange and the pooling mechanism by itself will provide even more benefit, but obviously it's a little speculative to make that assumption today, and that's why CBO, I think, erred on the side of caution. Next slide. Again, this is a single individual who, again, would be spending roughly about $4,200 for insurance if he or she was out in the market. Again, starting this year, she could just elect to get under her parents' plan, but if she were to enter the exchange on her own, again, her savings would be substantial. Next slide. In terms of, you know, the gross impact on the state of Connecticut, these next couple of slides again show the number of businesses that will benefit from the tax credits, the savings in terms of premiums for families by the existence and operation of the purchasing exchange, the average savings in Connecticut for families, the donut hole in terms of the number of Medicare beneficiaries that could potentially get help from the changes in the statute. And again, the list just sort of goes on in terms of the number of people who will get help. Again, these are figures which the Census Bureau and the Congressional Budget Office have put together in terms of the number of people in Connecticut who presently today struggle with the existing system and the help that they will get. Just kind of keep moving along here. Medicaid coverage in Connecticut will get a big boost in federal dollars. As Ellen knows, in the short term, Connecticut will be able to amend its Medicaid plan to enroll SACA patients, and by doing that with the federal match that would be triggered, the state of Connecticut would save $38 million. The Office of Fiscal Analysis, to my understanding, has also confirmed that savings. This is an approach that the Connecticut Hospital Association is very supportive of, and hopefully DSS is going to move quickly to implement it. Again, the law was specifically written to basically trigger that eligibility for states to April 10th of this year of 2010. So this is something that, again, Connecticut can take advantage of quickly. Federal funding for all the community health centers will get a boost. The other piece I just wanted to cover quickly and then open it up to questions is just the issue of Medicare and Medicare Advantage. I mean, there is no question that, from my experience from going out and doing town hall meetings at senior centers and just town hall meetings in general, that seniors are very concerned about the impact of the bill in terms of Medicare Advantage, the insurance product that's sold through the Medicare system. As this slide indicates, I think that there's been a lot of exaggerations regarding this claim, and frankly, I think the policy basis of making this change, which is a gradual equalization of Medicare Advantage rates with the rest of fee-for-service Medicare, I think is completely justified. Number one, and most important, is that the and the next slide we can jump to that if we could. Yeah, is that the...
Oh, sorry. Too far.
first of all, it's just that, the Medicare Payment Advisory Commission, which is the nonpartisan agency in Washington that oversees the operation of the Medicare program, for the last 5 years has come to Congress and said you are overpaying for this aspect of Medicare, 14% more than traditional Medicare. It is something that the chief actuary has calculated shortens the solvency of the Medicare Trust Fund by 18 months. And the net effect in terms of just an equity argument is that the 75% of Connecticut seniors who use fee-for-service Medicare are in effect cross-subsidizing people who are on Medicare Advantage. So to address this, MedPAC, which is again the nonpartisan group, and we can go to the next slide, is not abolishing Medicare Advantage. I mean, I've had a lot of seniors and people who've come up to me and said, why are you eliminating Medicare Advantage? This is not what in fact is happening. What MedPAC has recommended is that a gradual equalization, again, of the two populations that are served by the Medicare program, which over a period of time will result in savings of roughly $150 billion over 10 years. Next slide. Just go back quickly.
Oh, okay.
Sorry, the one, yeah, right there.
Okay.
Again, just to confirm that this is not, something that President Obama has been pushing, or the new Congress has been pushing because of ideological or partisan reasons. The MedPAC reports going to Congress recommending these adjustments go back as far as 2005. And, given the fragile state of Medicare's finances, to ignore those recommendations, which result in substantial solvency benefit to the Medicare program, again, I would strongly argue is just not justified. So next.
Sure.
Yeah. So again, number one, this does not abolish or eliminate Medicare Advantage. The legal authority for Medicare Advantage to operate is still in federal law, and we are not treating Medicare Advantage unfairly in the sense that we're shortchanging it compared to regular Medicare. We're just simply equalizing the two programs. Next one. And this slide just simply shows what the phase-in, which again doesn't happen in one fell swoop. The next couple of slides again just sort of walk through the impact. In Connecticut, just in terms of a Connecticut-specific issue here, is that we are paid for Medicare a little higher than the national median. So that means that the net impact to Connecticut's Medicare Advantage is actually less than other parts of the country. So in other words, the equalization ends up with a less drastic reduction compared to other parts of the country. And because Medicare Advantage is considered a higher quality, or the programs that are offered in the state of Connecticut are higher quality in terms of getting a higher ranking, they also, I think, are going to be better positioned to deal with this equalization because those plans that have the higher rating get a sort of a bonus payment for higher quality services. So, I just want to share this with you because it's something certainly a lot of us have heard out there on the street, particularly with older citizens in Connecticut who are worried about the impact on Medicare Advantage. We are not abolishing it. We are simply equalizing the payments. And as long as programs in Connecticut continue to show that they can offer decent quality, higher quality coverage, then in fact the impact is even less significant. And that it's just a red herring for people to attack this proposal as somehow hurting the Medicare beneficiaries. Overall, I think what we're going to see with Medicare is, as I've said earlier, the donut hole will be closed. We are eliminating co-payments for annual physicals for people who are on traditional fee-for-service Medicare, so that, again, your checkups will now be covered. Cancer screenings, preventive cancer screenings are now going to be completely covered through Medicare. I think you can make a very strong case that we are, in fact, strengthening and improving the system in terms of the beneficiary standpoint. So again, I know we got a lot of slides there, but Ellen will make them available, and I'll be happy to take a few questions before I head off to the next flood part of Eastern Connecticut, which is where we've been spending a lot of the day. So thank you, Ellen.
Sure, thank you.
Say hi. Yeah.
We have a question from Dr. David Henderson, who is my co-chair on the Sustanet Healthcare Workforce Task Force. And he also, in his day job, when he's not co-chairing with me, he is a family practice physician, a primary care doctor, and he is also on the faculty at UConn. And he asks, can you speak to some concerns raised by small business owners regarding perceptions that there are provisions in the bill that make it difficult to provide medication coverage for employees?
Right. I mean, there was when the Medicare Part D program was passed, there was some concern at the time that some of the larger employers who provided retiree benefits would simply sort of dump their retirees into the Medicare Part D program, and that in an attempt to avoid that from happening, there was a provision in there that allowed a subsidy for large employers to continue to provide prescription drug coverage, because it was felt that that would be cheaper than having them show up at Part D. In addition to the subsidy, though, there was also they were also given the ability to write off that subsidy, which is kind of amazing that they were given sort of two incentives to keep people enrolled in retiree coverage, both a subsidy and a deduction, which is probably unique in the history of tax law. So the bill still permits the subsidy to go forward for retiree plans, but it took away the deduction. There obviously has been a lot of blowback by AT&T, Caterpillar, some of the larger employers who are claiming that they're going to have to take a immediate write-down under their accounting rules for that. The chairman of the Energy and Commerce Committee, Henry Waxman from California, has already said that he's going to have hearings as soon as we get back at the end of the month in April. The administration feels very strongly that this is kind of eating with two forks by these companies who are still getting help as a way of incentivizing them to stay into keep their retirees covered through their plans, but that they should not get a second tax benefit from it. You know, but I think the doctor's question about businesses' questions and impact, you know, about the impact of the health care bill is critical right now. You know, one of the things we didn't cover in the slides, but I just want to make sure people understand, is that even in 2014, when the purchasing exchange goes into effect, firms of 50 or less are exempt from any employer mandate. They are still eligible to receive tax credits, as we saw earlier from one of the slides, if they do opt to provide coverage. And I believe, as someone who used to be a small employer, that most employers do want to you know, provide that type of coverage for the purposes of maintaining good morale and good workers. But there is no mandate on firms 50 or less to provide coverage. And if one of the employees enters the exchange on their own, again, if the firm is 50 or less, there is no penalty that's imposed on the firm, assuming they are of that size.
Okay, we have several other questions, but we'll put them in some order here. Jacqueline Ray from the Connecticut Mirror asks, Governor Rell has asked DSS and OPM to assess the costs of the new law to the state. Do you have any estimate of what financial impact this may have on the state's budget?
Well, as I said earlier, in terms of the short term, the state has an opportunity to save $38 million by taking advantage of Medicaid coverage for SAGA clients. And that's something which OFA has already analyzed because this is something that has been under discussion over the last year or so. In terms of other impacts, there is no increase or expansion of the Medicaid program until 2014. In 2014, there will be new populations that will be picked up under the Medicaid program, because it will be a program now available to all individuals at 133% of poverty or less. But in the first 2 years, the federal government will pay 100% of the cost of that coverage, unlike regular Medicaid, which, as Ellen knows, is traditionally been a 50-50 match. And over the next after the first 2 years of 100% coverage, it begins to sort of flutter down to 90% federal reimbursement by 2020. And that, as somebody who did budgets for the Medicaid program years ago in the state legislature, I mean, that is a rate of federal reimbursement that we couldn't even fantasize about back then. So this bill had a lot of input from the National Governors Association, from the National Conference of State Legislatures, and the Medicaid rates, were something that were looked at very closely, because clearly that program is going to be, a workhorse in terms of the new healthcare system. But generally speaking, the new populations that are going to be covered by it will be given extra help. I mean, lastly, I know there was a lot of discussion about the Yukon Health Center. The funding for a federal help for public hospital run by a state university did survive. It's my understanding there's at least 12 states that are interested in that program. There's no question the state of Washington, having talked to other members, is going to aggressively pursue this. So, that money's there, but I think it would be a mistake for anyone to go out and spend it as part of a budget right now until it clears the competitive grant process. And certainly Connecticut has learned over the last few months or so that competitive grants are far from a sure thing.
Mm-hmm. I don't know if you have time for one more question.
Sure, one more. Yep.
Okay, Cara Passaro, who is from the Speaker's Office here in Connecticut, wants to, and I think we all echo this, she wants to thank you for all your hard work on this. Earlier drafts of the bill included grant money that could be applied to state innovations. Are there funds available that could offset startup costs associated with setting up a public plan? And we talked about this earlier.
Yeah, the House bill, which was not used as the base bill for the health care law, did include that funding for state startups. It was not included in the Senate bill. Once the exchanges go online, though, there certainly is going to be funding out there for nonprofit initiatives to provide health insurance. Congresswoman Woolsey from California, after her review, she was a strong supporter of the public option, felt that there will be flexibility, again, in 2014 and beyond, for state purchasing exchanges to have that type of flexibility subject to the Department of Health and Human Services approval. But it's obviously an issue that's going to get some attention as this bill begins to become operational. But the specific incentive grants for states, which again many of us in the House supported, was not part of the final Senate package.
Right. Well, this is a work in progress, as we've said. I just want to thank you so much for doing this, and we'll be bothering you again and often, Joe, down in Washington and up here as well. And I also want to thank your very exceptional staff, Maya Welton and Ellen Paul, for helping set this up and making us all sound so smart. Thank you very, very much.
Great. Use this as a resource.
Thanks.
Yep. Bye-bye.